Welcome back to Stop Feeling Like Shit. And I'm your host, Danielle LaCourse. Dr. Buzz isn't here again, but not to worry. We have our favorites in the house, Joseph Matovich and Dr. Mac
Hello, everybody.
from Buckeye PMR and Anti-Aging, ready to crack your back and fix all your anti-aging needs. All right, let's just get to it. I was trying to be funny. So today's episode's a little different. We have been getting a lot of questions on social media and a lot of recommendations and with these questions. So we're just going to do like a rapid fire with some conditions and get some answers from you guys.
Absolutely.
So we're going to jump right into it. So one of the questions we got from an 85-year-old female with bone-on-bone knee. So what would we do in the clinic?
Okay. Well, if we're just doing processes and protocol, first, of course, we'll have her come in, fill out an intake. We would do some x-rays to confirm the bone on bone, and things of that nature. Once we do establish that, then we start talking about potential treatments and things of that nature and outcomes. One of the things I would do for a patient such as that is possibly A2M, alpha-2 macroglobulins, which is basically a treatment we use to help with stopping the enzyme that causes the arthritis, right? So when you're dealing with bone on bone, you're dealing with what we call degenerative joint disease, right? So when you're dealing with degenerative joint disease, you have a bunch of proteases that attach to the joint and are pretty much taken over the joint, right? So when it's taken over the joint, it's pretty much saying, hey, I'm here now. The healing factors that need to get there to pretty much slow down that process or stop that process can no longer get there and work, right? So now that process is no longer, that healing process isn't working, we have to go ahead and remove those proteases or bind or trap those proteases so the healing properties can get in there. And that's what the A2M does. So that would be the first process that we would do. After that, I would also probably would like to have some allograft umbilical cord tissue injections into that knee as well, because now we want to grow that or help that space to regenerate, right?
Yep.
So the meniscus, I would assume when you're bone on bone, odds are we would probably have an MRI done on this patient as well. The meniscus would be damaged. So if the meniscus is damaged, then we want to get some of that tissue back, and that's where the allograft umbilical cord tissue comes in.
Okay. And so, this patient, if you are someone listening and you've been told by your provider, you're bone on bone,
Absolutely.
you need a replacement. Guess what? Dr. Mac is saying, come in, you need to get an x-ray, MRI.
Yeah.
He can look at it, do some A2M, then follow up again with some Morton's jelly.
Because the trick here or the issue here is, unfortunately, with modern medicine, right? If you go to pretty much a orthopedic specialist, a medical doctor, whoever, that's their scope of practice at the end of the day, right? They're not out here saying and promoting A2M and promoting allograft umbilical cord tissues, Wharton jellies, and any of those type of treatments, right? So basically, if you're bone on bone, well, based off their course of action, it's pretty much surgery that they can do, because based off of the research that's out there that is pretty much being approved by the masses is there is no treatment for arthritis or degeneration or bone on bone, with the exception of a surgical procedure like a total knee replacement.
Right.
And I think that most people don't want to do that.
No, I want to keep everything I have.
Exactly. I mean,
right?
everything that God gives us, I think most people want to keep that, because the unfortunate reality is, I tell people, once you're cut on, they can't uncut on you. So
That's right.
even if, hypothetically speaking, let's say, why not even try that? Because the worst case scenario that can happen is you're just still bone on bone already. Now, I know people don't want to waste time, but once again, when you go to a drastic situation like going to surgery, there is no coming back from that. So when you take that step, you have to accept whatever you're dealing with after that. I think with the options I give, the worst thing that can happen to you is nothing.
Right. It doesn't work.
Yeah, it just
right?
doesn't work. So,
And I would always love to try that before cutting myself open and getting a replacement, right?
Yeah. Absolutely.
Okay, we got a 35-year-old male marathon runner with plantar fasciitis.
Okay. If I have that gentleman come in, course intake, we want to do a workup on him. So I do some testing to confirm that he has plantar fasciitis. After we confirm that, then one of the first treatments I would want to do is possibly PRP, which is plasma rich proteins. Excuse me, I'm sorry. And we do an injection into the foot, right? So we would do typically we only do one injection, but I've seen where some offices would do multiple. But what we do is we do the injection, and I couple that with shockwave therapy, right?
Okay.
So they would come in and do 6 sessions of shockwave therapy, because what we want to do is, once again, we want to rehab that tissue. So when we have a thin sheet of tissue on the bottom of our feet with plantar fasciitis, what happens is you get micro tears there. So he's a runner, right? That repetitive trauma of him constantly running leads to the stretching of that tissue, which causes micro tears. And when the healing factors are happening, the body's constantly trying to heal. So once that person is pretty much resting or sleeping or off their feet, but those tears start to heal. As soon as they put their foot back down, re-tear. So what happens is for most plantar fasciitis patients, in the morning is worse than throughout the day, because when they first go to put their feet down, they get that burning sensation. So what we'll want to do is we'll want to do that PRP injection and then follow that up with the shock wave, which helps to promote the body's natural healing ability to repair that tissue.
And wouldn't you agree that if you're alive and breathing, your body is constantly trying to heal and repair itself?
Every day.
I think that what the shockwave helps us as well, and you can correct me if I'm wrong, because we use it for ED, is it helps stimulate tissue remodeling, and it allows a patient to rebuild connective tissue that has more appropriate architecture.
Absolutely.
Because when you get, when we look at connective tissue, whether it be fascia or a tendon, right? All the fibers in that tissue should be organized in a uniform fashion that generally run parallel. We're constantly re-injuring tissue. We can get the accumulation of scar tissue too, which is just bad architecture.
Exactly.
Right. So with shockwave, it's nice, and we use it on our side of the practice as well, because not only does it facilitate angiogenesis and growth factor expression, but it helps with coupled with appropriate therapy.
Yes.
The remodeling of connective tissue architecture, so that new tissue, as it heals and repairs, is more uniformly formed and of better quality, so that it also prevents the likelihood of recurrence of that issue in the future.
Yep. So less re-injury.
I like to just shockwave my whole body. I mean, let's be real. All right, we have a 42-year-old male with degenerative disc disease and lumbar spine with radicular numbness and tingling.
Okay. So patient comes in, does a workup. Once again, we get x-rays, right? So we want to confirm to see what the lumbar spine looks like, right? Because me as a chiropractor, but also dealing with regenerative medicine as well, we always want to make sure we look at the structure and see what's going on with the structure, because I'm going to address that as well. But in that case, I would assume that that patient has some type of disc pathology. So if they don't have an MRI already, we would refer out and get an MRI so we could be as thorough as possible. So odds are they would come back with some type of herniated or protruding or bulging disc or disc pathology that is causing compression on a nerve. So one of the first things I would want to do with that patient is maybe possibly decomp. But it also depends on the integrity of the spine, right? So let's say I take an x-ray and we show that the severity of the degenerative disc disease is there, right? So then now we want to possibly do allograft umbilical cord tissue injections there to help that disc tissue to regenerate, right?
Yep.
So then that'll also help with that degenerative disc disease by opening up that space some more.
Okay.
So then we couple that with decompression therapy, which we typically do anywhere from 24 to 40 visits, depending on the severity of the condition of the patient, and we see very good results with that. So that combination of allograft umbilical cord tissue injections and the decompression therapy. And then I'm big on putting onus on my patients at home. So we got a group of guys that created some protocols for us to help with our patients to do stuff at home with stretching and re-educating their spine to make sure they have proper joint movement and proper joint function.
Wow. Okay, I love that.
And I would say, Mac, is just as I see you practice, for a lot of patients with more advanced disc herniations, you generally, as a rule of thumb, stay away from adjustments.
Oh, absolutely.
I know I was about to get to that, where I was going to say, you don't hear him saying, I'm going to crack their neck, crack their back first, right?
Well, listen, I'm as biased as they come as a chiropractor.
Yeah.
So, I mean, I think everybody needs it, but I also understand when and where and the why. So if I have a patient that's symptomatic like that and their disc is highly inflamed, and I know that pretty much putting them on their side and, doing a diversified adjustment on them would possibly cause them to be in more pain. And I would think when people are coming to see us, they're not going to leave with more pain.
Right.
So regardless of what I think is the best for them in that situation as a chiropractor, I'm going to adjust you and that's going to help you in the situation. No, I actually have a young lady that just came in last week who was highly inflamed. And she loves to get adjusted, but I had to really talk her down off the adjustment and say, hey, no, we're going to do a couple of weeks of decompression first with some laser therapy and then see how you respond. Well, I'm glad I did that, because once we did that, now she's back to the point where she's getting back to her day-to-day. Her symptomology has changed, and she's feeling a lot better. She's back into her normal routine. So now I told her, maybe I'll throw an adjustment in there and there, but that's not the end-all, be-all. That's not what you need.
Right.
You need the decompression.
Yeah, and I just want to throw this in here real quick, is that just because you hear the word chiropractor doesn't mean their first line of defense is always going to be like, well, I'm going to crack your back or crack your neck, like with what Dr. Mack does. You do have some of the chiropractors that are strictly
chiro, yes.
and they're cracking your backs.
Yes.
So what we're doing over here is regenerative medicine, right?
Absolutely. Absolutely.
So,
We take a multifaceted approach. And I think that's the beauty of Buckeye Physical Medicine and Rehab. I mean, we have, Joe and what he does, and then you have what we do on our side. But that workup we do in the beginning and the way that we educate and inform our patients, I've told plenty of patients, hey, no, the adjustment isn't what you need.
yeah.
We need other things. We need other intervention. And there's times where I've run into a patient being like, well, aren't you a chiropractor? You're not going to adjust me? You're not going to pop my back? And it'd be like, I look at him like, nope.
Yeah, no.
Well,
Yeah.
and I think what Dr. Mack mentioned, which I think is really important, and this is the lumbar spine's close to me because my lumbar spine's been fused since I was 22 or 23 years old, right?
Yeah.
Is the at-home treatment protocol that used with patients as well with the FRC matters a lot because even patients with back problems that go through physical therapy, they generally learn how for their back to be strong in an isolated or basically an isometric state when it's not moving.
Yep.
Well, the problem we see with a lot of people that lead to disc issues is the spine itself is just a big load-bearing system. And its capability to distribute load appropriately is largely dependent not just on the health of the discs, but the capability of those of individual intervertebral segments to articulate and move relative to each other.
Exactly.
So a lot of people have issues with their low back, and this was my issue where because of, and really what is a inhibitory or protective mechanism of the nervous system, right? Something's starting to go bad. So your body goes, oh, don't move this anymore.
Yes.
So you'll see a lot of people that have hard hinge points in their back where they start to, where their L3, L4, L5, S1 no longer move independently from each other. They move in a big chunk in a big segment, which puts all that load at the disc above that segment rather than it being distributed through the whole the whole spinal column.
Exactly.
So the therapy that Dr. Mack has patients do actually trains them to learn how to articulate and move intervertebral segments individually, and then how to progressively train those intervertebral segments to actually accept load in different positions. Because when do most people hurt their back, right? They don't hurt it when they're lifting weights, right? I mean, they can, but it's usually not, I was doing an isolated controlled movement. It's, I bent down weird to tie my shoe, or I sneezed or something like that. It's, they rapidly loaded a disc or put the spine under tension in a position it's not used to being loaded under. So, decomp's great because it creates active decompression. It creates a negative pressure on the disc and allows it to suck back into place and reduce inflammation. But he's also simultaneously having patients learning and re-educating their nervous system, re-educating how to move, and training the spine to be more resilient under tension at a multitude of positions so that now you can tie your shoe, or if you twist weird, you're not going to be back here on the table for 8 more weeks, or you're not going to flare it up. So it's not just decompression, which a lot of docs do. It's decompression coupled with retraining the nervous system and finding ways for people to actually improve intervertebral space under their own force and absorb load, right? Because that's it really, I mean, most
he hit it on the head. He hit it right on the head. Because you're not doing decompression in our office if you're not doing that.
Yeah,
right.
Because most injuries, connective tissue wise, are generally what you'd call a reactive strength injury.
Exactly.
Where your connective tissue failed when it was put under a load that it's not used to being put over under an angle it's not used to operating at. So Dr. Mack is also actively trying to eliminate those weak points where that tissue is going to fail, so that not only did we correct these acute symptoms,
We're dealing with the long term too.
but we're creating a long-term adaptation to protect you from it happening again in the future.
So it's not just about in the present, but it's also about in the future. We want to make sure. I always say, if we're good doctors, we're good at what we do, you won't have to keep coming back to me. Right. Like, you'll probably come back more on a maintenance tune-up basis, but not for a corrective basis all the time. I think if you got to constantly keep coming to me for correction, then I'm doing something wrong.
Yeah.
Well,
I agree.
And I think my back's been a testament to how we practice. Because again, I'm 16, 17 years post-fusion. By all traditional medical standards, I'm like 10 years into borrowed time.
Yep.
Because most people need, with fusion, you're up in 6 to 10 years. You're up another level, up another level, up another level. Yep. We've actually gotten to the point that my L3, L4 space is better now than it was after my spine surgery. I have the x-rays to prove it.
Yes,
and that's because of all the things that we're doing in office and all the things that I do outside of their training as well to create intervertebral space. So I never want to have another freaking fusion.
Yeah, you never, I mean, I think when people start getting cut on their back and their neck, I mean, just hang it up.
I mean, go look at the outcomes. I mean, not that I'm not bashing, I'm not saying it's necessary, but when they do those surgeries, go look at the percentages of the time you got to have a second surgery. It's like
Yeah.
a 50 to 60% chance you're going to have another surgery after that.
I had
Right.
2 in 5 years.
Yeah, so think about that. And he was young when he had his,
18 and
so
22 or 23.
you take the lumbar spine, I always say it's a 5-man job, right? So
Yep.
it's a 5-man job with the 2 lower ones being the stronger ones, right? So if you take one of those discs and injure him, and now that job, that man can't do his job anymore, but that's still a 5-man job. So now it's 4 men doing a 5-man job. They're going to get it done for an extended period of time, but they're going to wear out. So then when you say, let's say your L5 disc is damaged, and then now the other 4 have to take the load, but you never do nothing to correct that L5, what's going to happen is eventually that L4 is going to become damaged too, because it had to do too much work compared to when all 5 are working or operating at efficiency.
Wow.
So,
Wow.
and I love my back surgeon. I think he's a great dude, and I think he's a brilliant surgeon. So I'm not knocking him. It's just,
and that's somebody that works out and trained and been with this guy for a while. If he didn't tell you he had a back surgery, you would never know.
Never, ever,
You
ever.
would never know because of how he does move, how he's pretty flexible. He does a really good job. So like you wouldn't know by how he works out and things of that nature. So like he's a really good testament.
Yeah, I love that. Okay. All right. We have a 55-year-old female with bilateral neuropathy from diabetes.
Okay. So once again, we do a workup. We do a lot of neurological testing because I got to confirm it, right? So I got to see what's going on with the neuropathy. Once we get that information and we know what we're dealing with, then we get into our protocol. So I have a protocol where we do some A2M.
Yep.
Right, A2M on the feet, right? So we want to help with, once again, binding those cytokines, those inflammatory cytokines and things of that nature. That's what the A2M does to kind of traps that so it can allow the body to facilitate that healing process again, right?
Okay.
We also start doing stuff like infrared therapy. We do hot water therapy in the office as well. We do Tesla therapy as well. So those combination of those things, when we're talking about the laser therapy, well, we want to create more blood flow, right? So now they're already dealing with decreased blood flow, which is causing for the coldness, the numbness, the tingling in their feet, the decreased usage, things of that nature. They can barely feel. They're stumbling when they're walking, things of that nature. So we want to help with getting more blood flow down there. Well, we do that by infrared therapy and with the Tesla therapy as well.
Okay.
So that combination, but it's a long protocol too. So I'm very honest. So like our protocol, I believe, can go anywhere from 3 to 6 months because it is something that takes time for it to happen, because it's going to take time for the lining of those blood vessels, the lining of those the nerves to regenerate because they're damaged at this moment. So when anybody's dealing with diabetic neuropathy, you're dealing with damaged blood vessels, damaged nerves. So we got to re-educate and regenerate those areas.
Yeah. So, and I always say when people are coming in, let's say they have like arthritis in the knee and you do A2M, they're going to some people get instant relief, right?
Yes, they do. Now, I never promised that.
Right.
So I'm big on tapering expectations because the one thing you would never, so I don't use the word fix, right? So, I try to tell people I'm not God. So at the end of the day, I'm a human, but we're good at what we do.
Right.
And I'll stand 10 toes down behind the products and the things that we give our patients. With that being said, somebody's coming through the door, I can't tell them like, hey, you're going to be healed and your knees are going to go back to how you was when you was 18.
Right.
I would be lying, right? And then that person is going to feel like when their knees don't feel like when it was when they were 18, that they didn't get what they wanted, right? They didn't get what they paid for or what they were asking for. So one of the biggest things I try to do is taper expectations by saying, hey, if you was to get a 30 to 50% improvement, would you consider that a win? I haven't met anybody that said no to that. Right?
Yeah.
Everybody considers that a win. And honestly, I would brag and say we have a 100% success rate. I'm just not going to say that because we have ran into people who had the idea that they were supposed to be completely fixed after getting the treatment.
Right.
But the truth is they got improvement. They just didn't get it what they want or had expected.
Yeah. And I was going to say, compared to like, when I talk to providers and they're treating somebody, with A2M on the knee because of arthritis compared to neuropathy, it's like you can't compare those.
No.
Like with neuropathy, I always tell people, you better have like a year expectation.
I mean, it's that's why I say our protocol is 3 to 6 months, and that's depending on the severity of the neuropathy, right? So like I had a gentleman who was coming in a couple of earlier this year. We started end of last year, but he was in the office for 6 months. And he was coming in, he started off at 3 times a week. He did that for 6 weeks. And then we bumped it down to twice a week and then all the way down to once a week. And he got a lot of relief. Of course, it didn't, he wanted a little bit more, but he got a lot of relief. He definitely got the numbness and tingling to decrease. You saw his feet were really like blue. That's how cold his feet was. When he had come in, it was blue. By about month 2.5, 3, he didn't have that blue color in his feet no more. And this was in the winter.
Wow.
So like we noticing like but for him, he didn't see it that way at first, right?
Right.
So I'm telling him like, hey, your temperatures are going up. Like I'm like, are you noticing your feet is as cold? Or the only thing he was more concerned about was he was still losing his balance. But I also think that has something to do with another issue, which I was trying to educate him on before, which is why eventually he did end up going to get like brain scans done and stuff like that done. Come to find out he did have stuff going on that was causing incoordination and things of that nature. But he didn't know how to disconnect the two.
Right.
Once we started doing the stuff with his feet, he did notice like, hey, I do have a difference in sensation, but he was more caught up on the balance, which is why I'm big on taper and expectation and helping people understand what they're going to be dealing with.
Yeah. Oh my goodness. I love this. Okay. 25-year-old female post-ACL surgery.
Once again, we do our workup. We get big on getting the health history, right? So I would want to know the outcome of the surgery, how everything went. But A2M, once again, A2M is really good for post-operative surgeries like ACLs, right? Because now we worried about post-inflammation, chronic inflammation, things of that nature. Well, the A2M will come in and help with that. A2M also stops the process of degeneration because when you have surgeries, once again, you just did something invasive. Unfortunately, with surgeries, that's typically the fast track to degeneration and arthritis.
Right.
They had to cut on you and do something that's not natural per se, right? So now that I did something invasive, your body has to try to heal that. And once again, Joe talked about the tissue, but not just the tissue level, but even on the structural level, we're talking about the bones. Well, now we got to worry about all that stuff healing properly. But what happens is surgery is a trauma.
Yes.
It's a trauma. So now the body has a traumatic response to it. And typically that leads to a lot of those inflammatory cytokines and things of that nature. It leads to those proteases that's going to cause the arthritis or cause for that tissue not to heal properly. Well, if we do the A2M, we can end up entrapping those cytokines, and now the body's natural healing properties can do what it needs to do.
Yeah. Ooh, I love A2M.
Well, and I would say what's applicable, and this is really applicable to every case we just talked about, ontophoresis delivery of peptides.
Oh, yes.
Yeah.
Right. Specifically BPC 157 and TB 500.
Back up. Yes.
And these are applicable for any of the cases that just discussed. The ontophoresis being the patch delivery method that we use in office. The push patch obviously is delivered. BPC 157, right? Why would you use that? Well, one, it stimulates migration of growth factors. The big ones like fibroblast growth factor 2, fibroblast growth factor 7, growth factors that are involved in laying down specifically tendon fibroblasts. So like connective tissue remodeling, laying down new collagen, right? 2, regulation of inflammatory cytokines, TNF alpha, interleukin 1 beta, interleukin 6. So shutting off the inflammatory process quicker to make that healing environment more appropriate. And then angiogenesis, new blood cell proliferation and growth. BPC even has neuroprotective effects, reduces neural inflammation as well. And then TB 500, a lot of the same characteristics in regard to growth factor migration and angiogenesis and inflammatory regulation. But that one's a really nice one too to use in combination because it also stimulates stem cell proliferation in areas of damage. It's better systemically at cell migration, and then it helps regulate the extracellular matrix of connective tissue as it lay down, which basically means it helps facilitate you laying down new quality tissue with less likelihood of scar tissue accumulation. So the combination of those, especially immediately after surgery, you could even make an argument for using them a couple days beforehand, essentially, primes the underlying biological mechanisms that drive repair to be in a pristine state. So whatever intervention we're doing is most effective, whether that be an intervention in the office or because somebody is doing surgery. The other thing, obviously, that we do in all of these cases is also functional medicine.
Yes.
Yep.
Right.
Yes.
And that's working on the adrenals. That's working on the gut microbiome. That's working on the underlying, basically what I say is the organic chemistry of cellular function. To make sure that we're doing everything we can from an endocrine perspective to make sure that person's in a state to heal, to make sure that we're doing everything with the gut to mitigate things like leaky gut that creates a pro-inflammatory state systemically, and then the organic acids to optimize cellular function and help facilitate meeting the bioenergetic demands that are required to actually heal.
Yeah.
So
I was going to say, if you have sky high cortisol levels,
Yes.
good luck healing your body.
The body is not going to heal.
Right. So I think that's very important for people to understand. You can be doing all the things.
Yeah.
Really. You can be doing all the things, people. But if your cortisol is out of control and it's high, you're not healing.
That's true.
Period.
And that's I saved to add those because I could have added everything I just said after every single case we just
that's
had.
very true.
So it's better just get through the cases and then explain.
No,
where
he's
that
right
comes
because I
in.
mean he's very right. I mean even today, I have a young lady came in today, bilateral knee. She's 50 plus, bilateral knee degeneration. We signed her up. We got her going on the A2M protocol, and then we got her going with 2 boxes of BPC BPC 157 patches, and then we also got her doing FRC. Right.
Okay.
So once again, we talked about FRC for the spine. We can also do FRC for the knee. If it has a joint, we could do FRC for it. So we want to make sure we put the onus on her to be doing something for her knees to re-educate properly, right? To make sure that tissue heals properly and then to go from there.
Yeah, I like that. I agree. And a 17-year-old male football player post-op meniscus repair wants to be ready for next season.
Okay. So, I mean, really still similar. BPC 157. Being that Joe brought that back up, definitely. With a 17-year-old. I would probably still want to do A2M with this kid, right?
Yep.
So we're talking about a 17-year-old. The beauty of a 17-year-old body compared to us old folks up here is their bodies naturally bounce back faster than ours, right?
Yep.
But what me being a former athlete and also coaching and doing things of that nature, one thing I see a lot is rushing kids back, right? So the first thing would be to make sure that the knee is strong enough, right? Now, we're going to do our A2M and things of that. Well, actually, I could probably do PRP, but I would still prefer A2M. I could still prefer because he's 17, so PRP could be helpful, but A2M is more potent. So I would like to do A2M to, once again, facilitate more healing properties and to speed it up. Because a lot of times it'd be just the natural healing, letting that kid go through his natural PT, things of that nature. And like I said, they'll bounce back. And we see for the most part, most kids do bounce back and be fine. But depending on the time frame that he have, I think the A2M will help to speed up that healing. And then after that, of course, FRC, BPC 157. But I would probably have that kid come in and do treatment in the office right after he does his injection. So we do knee decompression at our office. So I think that would be very beneficial for him. Wish I would have been able to get the kid prior to the tear, but if in this case we have him after the tear and after the surgery, I still would probably want to do knee decompression, possibly some laser therapy as well, maybe even some shockwave therapy as well. So we had a combination of therapies we can do that we can figure out which is the best for that kid, but definitely A2M and a combination of those therapies, some BPC 157, and then also some FRC for him to put some onus on him to re-educate at home.
I love that. Okay. So from listening for you to go over these protocols and conditions for these people and plans, if you're a provider listening to this and you practice regenerative medicine, you're integrated and you do all these things, we love A2M. And so if you don't know what A2M is, definitely reach out to us because it is, I think, a game changer. A game changer for people. We love A2M and the practice. And then also the BPC 157 with the iontophoresis. Game changer. Because a lot of people will say, oh, I inject BPC 157. I talk to providers and they say, I already have my patients injecting BPC 157. And I always say to them, that's correct, but how often is your patient injecting? It's typically 1 time a day, right?
Yep.
And in order to, when you're injecting 1 time a day, just imagine if you could take your patient, put them on a 12-hour patch, and you're loading them up with what they should do if they're injecting 8 to 10 times a day, right? There's so much, and it's a slow release over 12 hours. So it's so powerful, right? Very powerful compared with what you're doing in the clinic with all these other therapies. It's totally amazing.
I know you see it because, I mean, we do the patches now mostly. We used to do the injections. Have you seen the difference in the patients that did the injections compared to the patches and how they feel and what their outcome or their response to it was?
Well, outcomes with patches is great, and just for reference, the half-life of injectable BPC, roughly, it varies person to person, but it's about 30 or 40 minutes, right? By general rule of drug metabolism, it takes 5 half-lives to eliminate something pretty much completely. Right. So within roughly 2.5 or 3 hours, that BPC that you injected is gone. But within 30 to 40 minutes, half of it's gone. Right. So it has very effective but very diminishing values where if somebody's adamant, they're like, I want to use an injectable. I'm like, well, at least for the initiation of care, you better be willing to inject this at least twice a day.
There you go.
Yeah.
Right.
Yep.
But with the antifreeze, in a general injectable dose, maybe 250 to 500 micrograms per
Yeah.
dose, right? 500 if you're going to be a little bit more heavy-handed, which honestly, if somebody's going to inject it, I'm like 500 twice a day,
Yeah.
right? At least for the first week.
Yep.
But the antifreeze patches have 2,000 micrograms a patch, but it releases gradually over 12 hours. So you're not even hitting that short half-life until that patch charge is worn out. So you're releasing 2,000 micrograms for the better part of an entire day before you even have to worry about drug elimination. So when we're talking about the efficacy of BPC, which is a very effective molecule, higher dose for an extended period of time just facilitates so much more healing, right?
Yeah.
And you do have to overcome the belief that if it's at the end of a needle, it must be more effective. But, Daniela, we know based on the testing that we've done on those Ionto patches, you can get comparable uptake off of those patches as long as the powder is formulated correctly and the charge is correct, comparable to that of what you get off of an IV delivery.
Yeah.
So the efficacy is phenomenal, and patients do come back much, much quicker, right?
Yeah.
They come back quicker, and the response is better. It's monetarily probably even a little bit better than the amount you'd have to take injectably, right?
That's my favorite patch.
Yeah.
BPC one. I mean, we see with BPC, it's like, I always tell people 1 patch, 2 patches is wild with what we see.
It is.
It's crazy.
Yeah.
Yeah. I mean, literally, I've had patients where, they might be in a little bit more chronic pain. They might come to see me maybe they're dealing with some back pain and they're coming for the chiro side, right?
Right.
We get them adjusted. They 1 or 2 weeks in, they're still struggling. And I'm like, all right, hey, let's do this. How about let's get you a BPC patch and let's see how you feel, or let's get you through a loading phase of BPC. But honestly, that first patch or the second patch, they like, I felt good. I slept great. This, that, and the other. They normally have a really great response after the first or second patch.
I know, it's wild.
That compared to, years ago when people were doing the injections, you had people that still responded well, but we didn't get that wow factor.
Right.
I think I get a little bit more wow factor from the patch.
Yeah.
Well, and the other thing within the patches that we're not even talking about is they also have NAD in them.
Yes.
Right.
They do.
Which is only going to support appropriate mitochondrial function. It's going to improve cell efficiently. There's going to be anti-inflammatory properties with that, and it's going to help better meet the bioenergetic demand of somebody who's healing. So, when you look at what you get off the patches, it's pretty remarkable.
Yeah, I agree. Well, would you like to add anything else?
No, just thank you for having me again.
You're welcome.
I appreciate it. I love you taking this time out to allow us to come here, and I'm just grateful.
I love it because we're hopefully, not only are people listening, providers are listening, and that's what we're really trying to do. Our goal is to help people, providers, provide better patient care in the clinic, right? Mm-hmm. And to get these outcomes, to get faster outcomes as to what they're getting now. So I love this episode, one of my favorites, because we're talking about real people asking real questions, and we get to sit here and give testimonial on your patients, right? Joe being a patient as well, which is a great testimonial because of your back
as well. So when I was talking about testosterone, everything you were saying, I've lived that.
Yeah,
I
have too.
My quality of life, like things that happened with me. I mean, I got to a point. I think I started taking it when I'm 40 now, so I think I started taking it 3 or 4 years ago. So I was 36, 37.
Okay.
And just off of that, I mean, my sleep quality, my body composition. It wasn't that I was just this crazy fat boy anyways, but I've noticed a difference in how my body changed. I mean, Joe noticed it because we hear him work out a lot. Even that, I mean, I'm stronger than I was when I was a football player at 20.
Yep.
Right?
Yep.
So like I'm looking at all those things and I'm like, wow, like, I see the benefit of it. And so much so that I'm always advertising to all my friends and people that I know as well. Definitely. I mean, my friends are 40. I'm like, you need it.
Yeah.
You need it. They are, I feel good. No, you don't. You need it.
Yeah, exactly.
You need it.
Yeah. No, and it's a huge testimonial because it coming from us, like we've lived it, we've been through it, we felt like shit, we've had, all the symptoms that we have, right? You can't sleep, you have brain fog, low energy, no sex drive, you're getting fat around the midsection,
yes.
You can't lose weight, it's like, oh my gosh, like what do we do?
So when you couple that with the fact that we got all these regenerative services too that we can use with the BPC 157, with the A2M, with the allograft, with PRP, with all those different therapies that we use and regenerative things, I think that we're getting our hormone, getting right on the hormone level, but also getting right on the musculoskeletal level as well. That combination, a lot of that stuff is interconnected.
Yeah, that's why I love the practice.
Yes.
Because it's combined, right?
Yes.
Got all the tools.
Got all the
shop.
tools.
We try to be a one-stop shop for you.
I love it because I don't want to be driving all over town.
Right.
All right, listen, if you have any questions about what we just talked about, A2M, the iontophoresis push patch, BPC 157, NAD, which is really awesome. Anything, stem cells, PRP, what Dr. Mack is doing in the clinic. If you're listening to this and you're like, well, I just had a surgery or my back hurts, call Dr. Mack, okay? Or just ask a question. We love to answer your questions. Thank you so much for being on the show today. And definitely tune in for the next episode. It's going to be a good one. And we'll catch you around later.